Good morning, everyone. My name is Sean. I'm one of the new EM interns. Today, my clinical prose lecture is going to be on the chest X-ray approach to diagnosing pneumonia. Before every presentation, I'd like to give a little outline where exactly we're going. So we're going to split between 5 different chapters. The purpose of today's presentation, we're going to have a case presentation, and then the nuts and bolts is going to be learning 2 specific signs on a chest X-ray, followed by takeaways and references. So chapter 1, the chest X-ray approach to diagnosing pneumonia. Now you all are probably wondering, why exactly are we using a chest X-ray to diagnose a clinical diagnosis of pneumonia? We also have radiologists. I don't care, right? This is a little joke right now. This is going to be a very interactive presentation. So let's lighten up a bit, but pretty much, it's really important for us to, use all different modalities in diagnosing pneumonia or different clinical diagnoses in the ED. But the importance of this presentation and exactly why I wanted to go over this, there's a 2019 article from the International Journal of Infectious Diseases that sought to determine the accuracy of diagnosis of pneumonia in the ED. And highlights from the article shows there's an overdiagnosis of infections that can lead to antibiotic prescription. Next, 1/3 of the ED pneumonias are discordant to the IM diagnosis. So when our patients go upstairs to the room, we have upstairs to the hospital, we have IM doctors that say this actually wasn't a diagnosis of pneumonia. The assistance of radiologists might help, but as EM docs, we should always read our own films, and reducing the overdiagnosis could minimize the antibiotic over prescription. So now Cardi B understands why we actually need to know this. So chapter 2, case presentation. We have an 81-year-old female, past medical history of hypertension, type 2 diabetes that complains of cough and shortness of breath. We get some vitals on our patient, and we see that she's tachycardic, she's tachypnic, she's sat in 93% on room air, and she's febrile. We do a physical examination. Pretty much we have a reassuring physical examination. However, it's notable for rails in the left lower lobe. All right, so chapter 3, we're moving on to the chest X-ray interpretation. So we order a 2-view chest X-ray. And if it's your first day of intern year, you're looking like this, like I was, like Steve Harvey, but we're not gonna panic. We're gonna go over this together as a unit. All right, so let's recalibrate for a bit. And I'm gonna give you all about 20 seconds just to analyze this chest X-ray for yourself. Hopefully y'all don't fall asleep. Okay, you guys are good. So turn it on good. Sorry, y'all. So there's different mnemonics for actually analyzing chest X-rays, right? There's different ABC models. For this specifically, I'm gonna ask for some interaction. All right, so it's gonna be interactive. So can someone tell me the A?
Airway.
Cool. Is the trachea midline? Is it like shifted? It's midline? Phenomenal, thank you. Can someone tell me the B?
The lights have to go off.
All right. Don't fall asleep, y'all. All right. Bones, are there any fractures? Okay, there's no fractures. Thank you, guys. C, how's the cardiac silhouette? Can someone, come on, guys, let's be interactive.
Normal.
Okay, cool. And then we see some blunting of the left costophrenic angle, right? D, the diaphragm, how does that look? Thank you. Okay. So there's some hazy opacity covering the left diaphragm, as we said, with the blunting of the costophrenic angle. Any effusion or extra thoracic soft tissues? Okay, sweet. And the fills, what do we see? I heard someone say, oh, I see it. What do we see? Okay, right. So we see a left lower lobe pneumonia, consistent with our physical examination where we had the rails, right? So
One thing with pneumonias behind the heart, if the patient's not too sick, it's good to get a lateral, send them up. Because sometimes it's hard to see behind the heart, and the lateral, what you'll see is if as you're coming down normal, it should get lighter. And if you see a big blotch behind the heart on the lateral, that tells you that's a pneumonia that on the PA or the AP is you can't see very well. So that's a very useful view for pneumonias on the left side behind the heart.
thank you, Dr. G. And we're gonna speak about a couple of those signs coming soon. So good job, Jessica, and thank you for that. All right. And everyone else, thank you. All right, so we're gonna move on to the two signs, which are the nuts and bolts of this presentation. So at this time, you know, we ordered a two view, right? So we have a PA and we have a lateral view. I just want to, you know, this is a perfect time to say there's not always a time where we're going to order a two view, right? It depends on the severity of our patient. It depends on the resources that we have. And actually, you know, there's other stronger methods for diagnosing chest X-ray if we wanted to use different tools such as a POCUS. In terms of a recent 2020 article, it showed that the chest X-ray is actually 72% sensitive for diagnosing chest X-rays, while a POCUS is about like 92%. So half of the time, once again, it's a clinical diagnosis. If we don't see the presence of anything on a chest X-ray, that doesn't necessarily rule out the diagnosis of pneumonia. We're still going to treat our 81-year-old female accordingly, just off of the physical examination. But this is a good time just to bring that up. Once again, the chest X-ray is not the end-all be-all for pneumonia. So the silhouette sign. This sign is going to be more revealing on the frontal views of your chest X-ray. So based off of the location of the haziness, it'll tell us the pathology behind the disease that we're actually having, right? So once again, always correlating it to the clinical picture. We have an 81-year-old female shortness of breath and coughing. More so is going to be a lower lobe lung disease as opposed to a lung or pleural rib disease, like in case of the chest wall in point number 4. Just want to say a positive silhouette sign does not necessarily mean that you only have pneumonia. It's based off of the location on the actual chest X-ray. Moving forward, now we have a spine sign, which is going to be more apparent on the lateral view. As we go down the spine, your spine should be more radiolucent. So a positive spine sign does not necessarily mean that the patient only has pneumonia, but it's some pathology of the lower chest. So once again, we're always going to go back in terms of the clinical picture of our patient, not necessarily saying, okay, a positive spine sign is indicative of pneumonia, but correlating back with our clinical picture, these two signs help us out with our diagnosis. Okay, so we have a pop quiz. This is the interactive part, please. Can someone please analyze the chest X-ray? We have a 35-year-old male complaint of cough and shortness of breath. Can someone tell me the consolidation and if it's a positive silhouette or a positive spine sign, please? Okay. Okay, I heard positive spine sign. I heard positive silhouette. Anything else? How's the costophrenic angles? Are they sharp on both sides? Phenomenal, right? And a bonus question, what bug usually causes this type of pneumonia? This is a lobar pneumonia. Good job, guys. All right, so takeaways, the chest X-ray approach to diagnosing pneumonia. We're not gonna panic, right? We're gonna read our own films. We're gonna go through it in our own process, knowing that there's different mnemonics. There's also the RIPE ABCD, which pretty much tells us the quality of the chest X-ray. We're gonna focus on the lung fills, in this case towards the chest X-ray approach to diagnose pneumonia. And we're gonna look for our signs, all right, that we just learned. And remember, you're a genius. All right, references. And thank you.